So we're going to talk first of all about the epidemiology of pulmonary embolism. What you see on the left-hand side of this slide is a depiction of normal electrical pathways, and at the bottom of the slide you can see normal sinus rhythm, and for those of you in the public, non-clinicians, these P waves that I'm pointing out here really are the indicator of a normal sinus rhythm where the heart is beating as it should and the risk of stroke is very low. On the right-hand side, though, you see what look like these very chaotic, abnormal electrical pathways. There's no particular pattern here. It's just pure chaos. And when you look at the electrocardiogram, those nice-looking P waves are gone. And you see a chaotic-looking rhythm. That's the hallmark, the electrocardiographic hallmark of atrial fibrillation. Atrial fibrillation is defined by an uncoordinated atrial activation, and there's consequent deterioration of atrial mechanical function. Ordinarily, the atria beat first and then the ventricles. If you lose the kick of the atria, the cardiac output decreases by about 20%. And that 20% can be awfully important. Now, there's a lot of terminology related to atrial fibrillation, and we need to get on the same page to better speak the same language for this evening's dinner symposium. And AF terminology, the groundwork is in what's called the 3 Ps. P for paroxysmal, that's a self-terminating type of atrial fibrillation. P for persistent, a type of atrial fibrillation that's not self-terminating, that usually lasts longer than 7 days. It might require drug therapy or electrical cardioversion to restore normal sinus rhythm. And then P for permanent atrial fibrillation. That's where cardioversion has failed or has not been attempted. Tonight, we'll be talking more about permanent atrial fibrillation than about paroxysmal or persistent atrial fibrillation, but the risk of stroke is there for all 3 types of atrial fibrillation. And we're going to be talking this evening mostly about atrial fibrillation that's not related to cardiac valve disease. So this is non-valvular atrial fibrillation. On the right-hand side, you see the hemodynamic consequences. Fatigue, of course, if you've lost 20% of your cardiac output, you're going to feel tired. Shortness of breath, palpitations, because many of us can sense an irregular rhythm of the heart when we lose that normal P wave and that normal beating. And this can develop into congestive heart failure. And then, importantly, is embolic risk, the risk of a stroke from atrial fibrillation. Well, why do strokes occur in atrial fibrillation? Here you see a part of the heart within the left atrium called the left atrial appendage. It looks a little bit like an appendix. It has this elongated shape. And hiding inside the left atrial appendage is a blood clot, a thrombus. This is an echocardiogram, but it does not come from the usual surface echocardiogram where the transducer is placed on the chest. Because if you look on the chest type of echocardiogram, you cannot visualize the left atrial appendage. This echocardiogram requires actually swallowing the transducer so that the transducer is in the esophagus, because the left atrial appendage is just adjacent to the esophagus. And only if you do the special type of echocardiogram can you find these clots that are hiding there. And when these clots break off, they will often cause strokes, and these strokes are major strokes for the most part. 1 in every 6 of these strokes is fatal, and of the non-fatal strokes from atrial fibrillation, about half of them result in major residual neurologic disability. Atrial fibrillation is the #1 preventable cause of stroke, and we project by year 2050 between 12 and 15 or 16 million Americans will be affected by atrial fibrillation. Why is the number of patients increasing exponentially? We think it's for a couple of reasons. #1, we clinicians are getting so much better at helping people survive heart attacks that they then survive the heart attack, but over the next few years develop congestive heart failure. And congestive heart failure is a risk factor for atrial fibrillation. The other issue is that, fortunately, the life expectancy in the United States is increasing, and AF is more often than not a disease of the elderly. I, in my own practice, have 4 patients over age 100, and I don't particularly specialize in elderly patients. I take all comers in my practice from age 14 to 100 plus, but you'll find more AF patients in the elder brackets of age 80 and over, and as we have the graying of America, the incidence, the prevalence of AF is increasing. Now, here is a cruel irony. You see here the prevalence of atrial fibrillation in women, shown in red, and in men, shown in gray. And in each decade, women have less AF than men. But ladies, don't rejoice too quickly. Unfortunately, for reasons we don't understand, women have a much higher stroke rate than men from atrial fibrillation. So overall, just being female is a risk factor for stroke from atrial fibrillation. The other important point is, as we age, the proportion of strokes attributable to atrial fibrillation increases. So overall, AF is responsible for about 15% of strokes. But when you get to those aged 80 and older, atrial fibrillation can account for about double that, 30% of all strokes. Now, what should we do with atrial fibrillation? Often the heart rate may become rapid with atrial fibrillation. Should we just accept atrial fibrillation and control the heart rate with a heart-slowing medicine? Or should we use other medications to try to convert permanently the heart rhythm from atrial fibrillation back to what we call a normal sinus rhythm? Well, here you see a study in more than 4,000 patients with atrial fibrillation, and these patients were randomized to a strategy of rate control. In other words, getting the heart rate down to around 80 or so. It can go easily to 120, 130, 140. Or to rhythm control, where more specialized medications are given to try to convert the heart rhythm from atrial fibrillation to normal sinus rhythm. The surprising finding in this study is that the stroke rate is basically the same in both groups. So even if one succeeds in converting the patient's heart rhythm from atrial fibrillation to normal sinus rhythm, the stroke rate does not go down. We're not entirely sure why that is. One theory is that the conversion to normal sinus rhythm isn't for 24 hours a day, 7 days a week. It's just for the 12 seconds of the electrocardiogram in the doctor's office. And then doctors like Dr. Gabay and I think we're in good shape, but we know that statistically these patients may be going in and out of atrial fibrillation when they're not in our office. Now, how do we assess the risk of developing a stroke in atrial fibrillation? There are new data on this, but first let me tell you the old way of doing it, which has been widely used the last 10 years or so. It's called the CHAD score. CHAD is an acronym for congestive heart failure, hypertension, age greater than 75 years, diabetes, and stroke. The maximum score you can get with this CHAD score is 6 points, and for each point of the CHAD score, your stroke risk increases. But I want you to note, even with a CHAD score of 0 or 1, you can have a stroke rate per year of 2 to 3%. But if you have a CHAD score of 6, it goes up to 18%. The old way of thinking about this, and this has changed as of 2012, is that if you had a CHAD score of 0 or 1, don't worry. Now we're worried about the strokes that can occur with these low CHAD scores. And the new way of redefining risk really started in Europe and was vetted by the Europeans, and now it's coming across the Atlantic Ocean, and it's pretty well accepted in the United States that we're redefining the risk, and we're worrying more about the patients with a low CHAD score, and we use this European CHADS-VAS score. It's particularly useful if we get a CHAD score of 0 or 1. Then we pull out the CHADS-VAS score, and we see if the patient really is at low risk. Because, remember, 2 points of the score system, you need to be on indefinite duration anticoagulation. So what does the VASC add to this? If you have vascular disease, a previous heart attack, cerebrovascular disease of the brain, renal disease, peripheral arterial disease, you get an extra point. And then we realize that age, the risk with age starts at age 65. You get a point for being 65, and that's 65 to 74-year age range. And if you're 75 or older, you get 2 points because age is so sensitive in predicting the likelihood of a stroke. And then finally, the sex category, the last part of the VASC acronym, we acknowledge that women get more strokes from AF, so being female is a risk factor in itself, and you garner a point. And so now we're saying the new way of doing this is that if your CHADS-VAS score is 2 or greater, the guidelines in Europe, and I think pretty soon the guidelines in North America will be to treat with indefinite duration anticoagulation. So we're taking the pool of patients with atrial fibrillation and we're anticoagulating more of them than we used to in the old days. Okay, what is the evidence that anticoagulation works? So let's start with aspirin. When we pool all the studies of aspirin against placebo for stroke prevention and atrial fibrillation, aspirin confers a 19% reduction in stroke risk. Some of the experts who are here tonight believe you should never give aspirin for stroke prevention and atrial fibrillation because the quality of some of these trials was not that great. Warfarin clearly is effective. When you look at warfarin versus placebo and pool the trials that have been done looking at stroke reduction in atrial fibrillation, you get a whopping 62% reduction in stroke risk by using warfarin. So warfarin has become the standard by which all the novel anticoagulants is measured against. What about warfarin versus aspirin? There were trials randomizing patients to warfarin versus aspirin. Warfarin's the clear winner, a 33% reduction in stroke risk compared with aspirin. So what is warfarin? Well, warfarin was discovered when cattle had major bleeding problems in Wisconsin, and the work was done at the University of Wisconsin, and probably the richest alumni foundation on the planet is at the University of Wisconsin, because Warfarin stands for Wisconsin Alumni Research Foundation. That's how they get the name. Some of you do know that warfarin is used as rat poison. Has a long, glorious history there. Warfarin is very complicated as a molecule. It works against many factors. It antagonizes many vitamin K producing factors in the liver, particularly clotting factors 2, 7, 9, and 10. So warfarin has actions all over the place. But despite its reducing stroke risk by 62% compared with placebo, despite its long, glorious history, being commercially introduced in the United States in 1954, there are some serious problems with warfarin. Some of you I know are here, are my patients. You've confronted these problems on a personal basis. It has a delayed onset and delayed offset. It can take 5 to 10 days to work, and it can certainly take a week to be totally out of the system. The dose response to warfarin can be unpredictable. Warfarin is measured its effect with the International Normalized Ratio, or INR. It has a narrow therapeutic index. It turns out that there are hundreds of drug-drug interactions with warfarin. We go to specialized websites now. We don't try to memorize them anymore because we're just discovering new drug-drug interactions with warfarin all the time. And there are also hundreds of drug-food interactions. The ones that are advertised the most are with green leafy vegetables, spinach, broccoli, Brussels sprouts. But there are actually hundreds of drug-food interactions. Monitoring warfarin is problematic. I know that a good number of you here work to help patients. You work in anticoagulation management services. And then the other frustrating thing as a clinician is even when we're doing everything right and we have the INR in our target range, which is between 2.0 and 3.0, there can still be a lot of bleeding. In fact, 40% of intracranial hemorrhages occur when the warfarin is within the targeted therapeutic range of 2.0 to 3.0. And finally, when we want to get rid of it in an emergency, its reversibility takes a while. So we're sort of between a rock and a hard place with warfarin. The target INR is between 2.0 and 3.0. If we get an INR less than 2.0, the risk of a thrombotic stroke increases. But if the INR goes above 4.0, the risk of intracranial bleeding starts to increase exponentially. Now, here's another problem. Warfarin is so difficult to use that on a public health basis, it turns out that many patients who, according to guidelines, should be receiving warfarin are not getting it. Or if they're receiving warfarin, their INR is not in the therapeutic range. Let's look at this study of patients with known atrial fibrillation, with no contraindication to warfarin, who presented to emergency departments with strokes. Patients where 100% should have been taking warfarin. 61% were receiving no warfarin. And of those receiving warfarin, only 10% of this total group had their warfarin in the targeted range between 2.0 and 3.0. And most of the rest of the patients had low INRs. This is the real world. Now, let's look at this study published recently in the New England Journal of Medicine of emergency hospitalizations for adverse drug events in older U.S. adults. These are U.S. adults coming to the emergency department with an adverse drug reaction, and the number of hospitalizations per 10,000 medication visits. Warfarin is number one offender. And in fact, of the top 4 offending agents, warfarin is responsible for 33% of the 100,000 or so emergency hospitalizations per year for adverse drug events in older Americans. Insulin, a very dangerous drug, came in second place at 13.9%. It's sort of tied with oral antiplatelet agents, and oral hypoglycemic agents was number 4. So warfarin causes a lot of emergency problems, a lot of emergency adverse effects. Nevertheless, warfarin is alive and is fighting to maintain its place with its history of excellent efficacy, its low cost, its long track record, the fact that anticoagulation management services can maintain the time within the therapeutic range greater than 60%, usually around 65% or so. Now, where I went to high school, 65% was a borderline flunking grade. And for those of you around here, that was the Roxbury Latin School. But in the land of warfarin management, everything is forgiven, and 65% you get an A for quality management. It may be in the future that we're better able to precisely dose warfarin according to rapid turnaround genetic testing. And we also have point-of-care testing where patients can test their INRs at home. Certainly there's much more patient satisfaction with home testing of INRs because patients become involved in their own care. And there's another finding recently published that if you're in that lucky small group of patients, and we see this in every anticoagulation service in the Brigham and Women's, we have about 3,200 patients in our anticoagulation management service. Well, about 300 or 10% of our patients every month, their INR is either 2.4, 2.5, or 2.6. Those patients can probably be safely tested once every 12 weeks. Here you see some of this genetic testing, rapid turnaround genetic testing in a cohort study, not a randomized trial. This group that had this intervention group, or IG group, that had rapid turnaround genetic testing, they had a lower rate of all-cause hospitalization and a lower rate of hospitalization for bleeding problems or thromboembolism problems compared to a historical control, or HC group. So rapid turnaround genetic testing is potentially promising. And there are 2 ongoing NIH-sponsored trials, each budgeted to about $10 million or so, which are testing the concept of rapid turnaround genetic testing for warfarin dosing, and the results of these should certainly be available by year 2015. We're going to hear a lot more about the specific novel oral anticoagulants, but their advantages, in a nutshell, is immediate onset of action. They're given in a fixed dose. There's no modulation of dose. There's no laboratory monitoring of INRs and no other coagulation testing whatsoever. There are minimal drug-drug or drug-food interactions. these novel oral anticoagulants, they have a very short half-life. And therefore, if the anticoagulant has to be stopped for a colonoscopy or elective surgery, you just withhold 1 or 2 doses of the novel drug and the anticoagulation's out of the system. And for reasons we don't entirely understand, virtually all of the novel oral anticoagulants have fewer intracranial bleedings, fewer head bleeds than warfarin. So I want to close with a vision statement and then some conclusions. Atrial fibrillation, the theme of tonight's dinner symposium, is a preventable cause of stroke. And women suffer stroke due to AF more than men, and the stroke rates due to atrial fibrillation increase with age. Even when atrial fibrillation is suppressed with medication, those patients maintain a high stroke risk. And the CHAD score, and now more recently, the CHADS VAS score, which like a fine wine we've imported from France and other parts of Europe, predict the likelihood of stroke from atrial fibrillation. Warfarin is difficult to prescribe because the dose is determined by the INR, and it varies up and down. There are hundreds of drug-drug and drug-food interactions. On the other hand, warfarin does have a long track record, and it is inexpensive, and it might improve in terms of our ability to regulate it if this rapid turnaround genetic testing pans out. I also want to say that in terms of atrial fibrillation, it's not only drug therapy that we have to worry about. We have to always think about the risk factors for atrial fibrillation that are in the CHAD score. And we have to put more emphasis on preventing the various risk factors, preventing congestive heart failure, preventing hypertension by maintaining a goal blood pressure, preventing and managing diabetes with heart-healthy living and heart-healthy styles. These heart-healthy and heart-conscious initiatives will help us also to reduce the atrial fibrillation rate and therefore the stroke rate. Thank you very much.